Hello everyone, we are group 4 and we will be discussing exercise 4. These are our group members. During this presentation, we will be answering the questions presented on the screen, which involve adverse reactions, effects, pharmacodynamics and pharmacokinetics of the drugs involved, along with pathophysiology and concept maps to make things easier for understanding. For the case introduction, DM, a 60-year-old housewife with multiple comorbidities including type 2 diabetes mellitus, hypertension, hyperuricemia, hypothyroidism, and hyperlipidemia. She presented with episodes of hypoglycemia despite being on medication. Her current prescriptions included losartan, atorvastatin, febuxostat, levothyroxine, and glimepiride. Past medical history and physical examination. The patient has a past medical history of cholecystectomy and total thyroidectomy. On physical examination, her vital signs were stable but showed elevated blood pressure at 140 by 90 mmHg and a pulse rate of 100 bpm. No significant findings were noted on EENT, cardiac, respiratory, abdominal, and neurologic examinations. For the lab results, they suggest glucose fluctuations, possible hyperlipidemia, and insulin resistance. Given the history of hypothyroidism, hyperuricemia, and diabetes, abnormalities in thyroid hormones, uric acid, and renal function may also be present. For the management, to prevent hypoglycemia, glimepiride was replaced by sitagliptin or metformin 50 or 500 mg twice per day for better glucose control with less risk of hypoglycemia. Lifestyle changes include weight loss, reduced sugar intake, exercise, and smoking cessation were advised. Regular monitoring of thyroid functions, lipids, and glucose and blood glucose is essential with a follow-up in 2 months to assess progress and adjust treatment if needed. Thank you.
Now let's discuss the pathophysiology of how the patient ended up with hypoglycemia. Hypoglycemia in this patient is a result of multiple metabolic disruptions, including hypothyroidism, altered fat metabolism, insulin resistance, and metabolic syndrome. Post-thyroidectomy, hypothyroidism slows metabolism and reduces gluconeogenesis, lowering glucose availability. Thyroid hormone replacement helps, but the imbalance can still occur. Cholecystectomy-related fat metabolism changes contribute to hyperlipidemia and insulin resistance, impairing glucose regulation. Hypertension and hyperlipidemia often coexist, requiring losartan and atorvastatin, which can indirectly affect glucose metabolism. Genetic predisposition to obesity and diabetes leads to insulin resistance, where the cells fail to absorb glucose efficiently, causing unstable blood glucose levels. Metabolic syndrome can worsen glucose control. Hyperuricemia, a consequence of metabolic syndrome, may require febuxostat, which does not directly cause hypoglycemia but is involved in metabolic dysfunction. The most common drug-induced cause of hypoglycemia is sulfonylurea use, which stimulates insulin secretion. Glimepiride, a drug our patient is on for diabetes, belongs to this class of drug. If we go to the next slide, here there is an image which illustrates sulfonylurea drugs blocking ATP-sensitive potassium channels, leading to membrane depolarization, which leads to opening of calcium channels that leads to calcium influx and ultimately increased insulin secretion. Excessive insulin secretion results in increased glucose uptake by tissues, leading to hypoglycemia if food intake is inadequate or glucose release from liver is suppressed. The blood glucose levels can reach dangerously low levels. DPP-4 inhibitors or metformins are preferred alternatives, offering better glucose regulation with a lower risk of hypoglycemia. Thank you.
Let's discuss the pharmacodynamics of the different drugs. For losartan, it is under angiotensin receptor blocker or ARB. It blocks angiotensin 2 type 1 receptors, preventing the binding of angiotensin. So this leads to the reduced angiotensin 2 levels, reduced vasoconstriction and aldosterone secretion, and it has no increase in bradykinin. Its adverse effects includes hypotension, dizziness, renal dysfunction, and hyperkalemia. Losartan is contraindicated in pregnancy, severe renal impairment, and with bilateral renal artery stenosis. It has high teratogenic risk because it can cause fetal renal dysfunction, oligohydramnios, is called hypoplasia, and even neonatal death, and it is not recommended in breastfeeding. For atorvastatin, it is under statins or an HMG-CoA reductase inhibitor. It inhibits HMG-CoA reductase, which is the rate-limiting enzyme in the biosynthesis of cholesterol. So this would lead in the reduced cholesterol production, and this would lead to increase LDL receptors or the upregulation of LDL receptors on hepatocytes, therefore increasing the uptake of LDL from the blood and lowers plasma LDL levels. So its adverse effects include myalgia, GI disturbances, and hepatotoxicity. Atorvastatin is contraindicated in liver disease, pregnancy, and lactation. It has high teratogenic risk because it can cause skeletal malformation and developmental defects, and it's not recommended in breastfeeding since it reduces cholesterol synthesis, which is important for the development of infants. So for the next drug is febuxostat. It is a xanthine oxidase inhibitor. It inhibits xanthine oxidase, which is the enzyme responsible for the conversion of xanthine to hypoxanthine and xanthine to uric acid. So this reduces uric acid production. Its adverse effects include gout flares, elevation of liver enzymes, rash, nausea, cardiovascular events, or cardiovascular risk. It is contraindicated in severe liver disease, renal impairment, and those with hypersensitivity reactions. It has moderate teratogenic risk. It should be used with caution because and alternative drug is preferred, such as allopurinol, and it's not recommended also in breastfeeding. So for levothyroxine, it is a synthetic thyroid hormone or thyroid hormone replacement. It is a synthetic form of thyroxine which is converted to the active form triiodothyronine or T3, and it activates nuclear receptors, resulting in gene expression with RNA formation and protein synthesis. Its adverse effects include palpitations, weight loss, tremors, tachycardia, and insomnia. It is contraindicated in adrenal insufficiency, myocardial infarction, and thyrotoxicosis. And it has low teratogenic risk or no known teratogenic risk. It is safe in breastfeeding due to its minimal secretion in breast milk.
Glimepiride is a sulfonylurea that stimulates insulin release by closing ATP-sensitive potassium channels in pancreatic beta cells. Its primary risk is hypoglycemia, especially in elderly or renally impaired patients. Other adverse effects include nausea, weight gain, hypersensitivity reactions. It is contraindicated in patients allergic to sulfonamides and should be avoided in pregnancy due to its risk of neonatal hyperglycemia. Breastfeeding safety is unknown, so alternatives are preferred. Sitagliptin is a DPP-4 inhibitor that increases incretin hormone activity, promoting glucose-dependent insulin release. It generally well tolerated but may cause hypoglycemia, especially with sulfonylureas, pancreatitis, respiratory infections, and hypersensitive reactions. It is contraindicated in patients with history of severe allergic reactions, and it has limited pregnancy data suggests caution, and its uses in breastfeeding is uncertain, so alternatives are preferred. Lastly, we have metformin, which is a biguanide that reduce hepatic glucose productions and improve insulin sensitivity. It's first-line treatment for type 2 diabetes, but may cause GI disturbances, lactic acidosis, and vitamin B12 deficiency. It's contraindicated in severe renal impairment, unlike sulfonylureas. Metformin is safe in pregnancy and breastfeeding, making it a preferred option for gestational diabetes.
Now let's talk about the pharmacokinetics of each drug. First is losartan. It is well absorbed after oral administration. It has significant first-pass metabolism, reducing bioavailability to about 33%. Peak plasma concentration is within 1 to 3 hours. It has approximately 98% plasma binding protein, primary to albumin. It has moderate volume of distribution. It is metabolized in the liver by CYP450 system, and about 60% of the drug undergoes liver excretion, and about 35% of the drug and its metabolites undergo renal excretion. Next is atorvastatin. It is also well absorbed after oral administration. It undergoes significant first-pass metabolism, resulting in bioavailability of about 14%. Peak plasma concentration is within 1 to 2 hours. More than 98% of the drug has plasma protein binding, specifically to albumin. It has large volume of distribution, and it is highly lipophilic. It is primarily metabolized in the liver by CYP450, and the major route is mainly through biliary excretion, and it also has minimal renal excretion. Next is febuxostat. It is also well absorbed after oral administration with bioavailability of approximately 49%. Peak plasma concentration is within 1 to 1.5 hours. It has 99% plasma protein binding, particularly to albumin, and it has moderate volume of distribution. It is also primarily metabolized in the liver by CYP450 enzymes, and it undergoes phase 2 conjugation reactions, specifically glucuronidation and sulfation. And about 45% of the drug undergoes fecal excretion, and about 50% undergoes renal excretion.
So next we have the levothyroxine, which is its absorption occurs primarily in the small intestine, particularly in the jejunum and ileum, and has an oral bioavailability of about 40 to 80%. It is highly protein bound, mainly to thyroxine binding globulin or TBG, and has a large volume of distribution of 10 liters. So the liver converts T4 into the active T3 form through the iodination. Some is also conjugated via glucuronidation and undergoes enterohepatic recirculation. Most of the drug is excreted via bile and feces, about 80%, with some renal elimination of 20%, and has a half-life around 6 to 7 days. Next we have glimepiride, and it is rapidly absorbed with a peak plasma concentration at around 2 to 3 hours, and a high oral bioavailability of 100%. It is highly protein bound with a volume of distribution around 8.8 liters, and the liver metabolizes via CYP2C9 into an active metabolite M1 and inactive metabolite M2, and this undergoes first-pass metabolism in the liver. It is eliminated through both the renal 60% and biliary system 40%. Its half-life is around 5 to 9 hours and can be prolonged in renal impairment. Next is sitagliptin, which is also well absorbed, and its oral bioavailability is around 87% with a peak plasma concentration at 1 to 4 hours. Sitagliptin has a moderate protein binding, about 38%, and a volume of distribution around 198 liters. Only a small fraction undergoes hepatic metabolism via CYP384 and CYP2C8. So most of the drug is eliminated unchanged through the kidneys via active tubular secretion through OCT2 and PGP transporters, and it may also be excreted in feces as metabolites, and its half-life is about 12 hours. Next So finally, we have metformin. It is absorbed in the small intestine and oral bioavailability is around 50 to 60% with peak levels at 2 to 3 hours for immediate release or 6 to 8 hours for extended release. Metformin is not significantly protein bound and has a large volume of distribution around 654 liters. So unlike many other drugs, this is not metabolized in the body. It is eliminated primarily by the kidneys via active tubular secretion through OCT1 and OCT2 transporters, and half-life is about 4 to 8 hours. It may also accumulate in renal impairment, increasing the risk of lactic acidosis.
So now we're going to talk about the indications and effects of these drugs. So first, losartan. This is an angiotensin II receptor blocker, primarily used for hypertension, heart failure, diabetic nephropathy, and stroke prevention. It works by blocking angiotensin II at AT1 receptors, leading to vasodilation, reduce the aldosterone secretion, and decrease blood pressure. It also helps slow the progression of kidney disease in diabetic patients. Next, atorvastatin. As a statin, it is prescribed for hyperlipidemia and cardiovascular disease prevention. It works by inhibiting HMG-CoA reductase, reducing cholesterol synthesis, and increasing LDL clearance, ultimately lowering the LDL, total cholesterol, and the triglycerides, while raising the HDL levels. And additionally, it has an anti-inflammatory and plaque stabilizing effects, making it crucial in cardiovascular risk reduction. So third, febuxostat. This medication is a xanthine oxidase inhibitor used for chronic gout and hyperuricemia. It works by reducing uric acid production, helping prevent gout flares and urate crystal formation. And compared to allopurinol, it provides a more selective inhibition of xanthine oxidase. And finally, levothyroxine. It is a synthetic T4 hormone used in conditions like hypothyroidism, goiter, and post-thyroidectomy hormone replacement. Once ingested, it is converted to T3 in tissues, helping restore metabolic function, increase cardiac output, and regulate thermogenesis. It is essential for growth and development, especially in infants and children.
Next, we have glimepiride, which is indicated for type 2 diabetes mellitus, and it increases insulin secretion by stimulating the pancreatic beta cells by binding to the sulfonylurea receptor. So it enhances peripheral insulin sensitivity with some evidence suggesting increased glucose uptake by muscle and adipose tissue. So it also reduces hepatic glucose production and indirectly lowers fasting plasma glucose by reducing hepatic gluconeogenesis. Next is sitagliptin, also indicated for type 2 DM, which enhances incretin hormone activity by inhibiting DPP4 enzyme, which degrades GLP-1 and GIP. It also increases insulin secretion, suppresses glucagon secretion by decreasing glucagon release from alpha cells, and it has no significant effect on weight, unlike sulfonylureas. Lastly, we have metformin, indicated for type 2 DM, PCOS, and also off-label uses for prediabetes, gestational diabetes, and also metabolic syndrome. So it decreases hepatic glucose production, increases peripheral glucose uptake, decreases intestinal glucose absorption, and there is no risk of hypoglycemia, unlike insulin secretagogues. So it also promotes weight loss, or it has a neutral effect on weight. So as for the patient in our case, the drug that likely caused the adverse effect of hypoglycemia would be glimepiride.
Now for the concept map, in the concept map, we have the division for the medications for hyperglycemia and medications for treatment for type 2 diabetes. Next. So for the medications for hyperglycemia, insulin is the primary medication for hyperglycemia and is categorized into short-acting and long-acting types. For short-acting, we have the regular insulin and rapidly acting insulin analog. It is used for immediate blood sugar control. And for long-acting, insulin including NPH, insulin glargine, detemir, and decidec, it provides extended glucose regulation. Next, please. Medications for treatment of type 2 diabetes. This is the drugs that primarily stimulate insulin release by binding to sulfonylurea receptors. So we have sulfonylureas, glutamate analogs for sulfonylurea and D-phenylalanine derivative. So for sulfonylureas like tolbutamide and glitazide, it enhances the insulin secretion. While the glimepiride, it is a medication used by a patient, and it stimulates insulin secretion from pancreatic beta cells by binding to the sulfonylurea receptors. And it is often prescribed alongside with diet and exercise. It could also be used alone or with metformin or insulin for better glucose control. Now for the maglitinide analogs such as the reptaginide and nutiglinide, it acts rapidly to reduce blood sugar. While for the diphenylalanine derivative like the nutiglinide, it also helps regulate glucose level.
Now, for the continuation, we have drugs that mimic incretin effect or prolonged incretin action. First, we have GLP-1 receptor agonists. Under here, we have exenatide, liraglutide, albiglutide, and dulaglutide. As for the DPP4 inhibitors or the dipeptidyl phosphate 4 inhibitors, we have sitagliptin, saxagliptin, linagliptin, alogliptin, and vildagliptin. Lastly, we have SGL2 inhibitors. This is basically the flozin, which are under here we have canagliflozin, dapagliflozin, and empagliflozin. Also, we have drugs that affect absorption of glucose. Under here are a few. We have vogliblos, miglitol, and acarbose. This basically inhibit the alpha-glucosidase enzyme.
Now, let's look at medications that mainly lower glucose levels by acting on the tissues. First is the biguanides, or what we commonly know as metformin. This reduces liver glucose production and improves muscle insulin sensitivity via the AMPK activation. It lowers fasting and postprandial glucose without causing hypoglycemia, making the first-line therapy for type 2 diabetes. Next is the thiazolidine. This enhances insulin sensitivity in adipose tissue by activating PPAR gamma, reducing insulin resistance. This includes rosiglitazone and pioglitazone. Next, please. So besides the previously mentioned, other drugs may also be used in diabetes management.
First is the bromocriptine. This is a dopamine agonist with an unclear mechanism, but thought to regulate glucose metabolism via brain signals. Second is the cholesivalam. This is a bile acid sequestration that modestly lowers blood sugar, but is mainly used for cholesterol reduction. And lastly, pramlintide. This is an islet amyloid polypeptide analog. This slows gastric emptying, suppresses glucagon, and enhances satiety. It is approved for insulin-treated diabetes to control postprandial glucose, particularly in type 1 patients with postprandial hyperglycemia. However, GLP-1 receptor agonists are preferred for type 2 diabetes. So that's all for our discussion, and thank you for listening.
Ayun guys, thank you so much. Tapos na tayo.
Thank you.
Thank
Thank
you.
you.
Uh,
Thanks, Emma.
Friends.